Okay, so this video is the fluid and electrolyte practice case studies. So what I will do is I will pause in between case studies so that way you can hit pause and work along with it if you haven't done them already. Please make sure that you're not just writing down the answers, that you are actually working through these case studies in order to see where your knowledge level is. So case study number one, we have a 55-year-old male. So question number one asks about what this type of fluid loss is. So you do want to make sure that you're talking about fluids, not electrolytes here. And so this is a dehydration state because we do have the hypernatremia. So it's not just a hypovolemic state because there is an electrolyte imbalance which goes along with dehydration. The nurse is assessing the body fluid state. What are signs and symptoms, laboratory data, things like that. So we have dry mucous membranes, dry skin, vital signs, particularly tachycardia, as well as increased respirations. There's an elevated sodium level, which goes along with dehydration for sure. Elevated hematocrit and BUN. There is definite weight loss, as well as a decrease in urinary output. So hypernatremia, number three here, frequently results from water depletion, from not having enough water intake or an excess of water output. What nursing interventions would help with this deficient fluid volume or this dehydration? Well, we need to make sure that we're monitoring the vital signs at least every 4 hours and comparing that with baselines. Now, depending on how dehydrated the patient is, that can be increased or decreased. Also, when we have a patient who is dehydrated, they are at risk for orthostatic hypotension. Should be checking that, as well as the safety procedures that go along if the patient does have orthostatic hypotension. We want to be encouraging hourly intake of fluids, and so we want to go with what the patient is, what the patient prefers, so that we can really increase that fluid intake. Monitor the IV flow rate, as well as for signs and symptoms of overhydration. So anytime we are giving the patient fluids, we have to watch that we are not overcorrecting. Anytime we're giving the patient, electrolytes or treatment for an electrolyte imbalance, we have to do the same thing. We always are watching to ensure that we're not pushing the patient into the opposite complication. We want to monitor skin turgor, mucous membranes for improvement, as well as deterioration, to see if what we are doing is actually helping. Definitely a daily weight. Daily weights are one of the most important things that we can do to monitor a patient's overall fluid status. Now, that is for most patients. Where this gets tricky is if the patient has a lot of third spacing, and we do have a case study that goes into more third spacing, and it shows why daily weights are not as helpful in identifying overall fluid status in that type of a patient. Also, intake and output, monitoring those labs, and regular urine-specific gravities. Okay, I'll pause for a moment before we move on to case study number two. Okay, case study number two is a 72-year-old female. So assessing her physical state, she has shortness of breath, coughing, swollen ankles. So what does this indicate? Well, this indicates a hypervolemic state. We don't have anything that tells us that there's an actual electrolyte imbalance. What this really indicates is that there is just way too much fluid on this patient's body. So now we're going to talk a little bit about edema under question number two. So this question might have thrown you a little bit. You probably got some of them, but not all of them. So here I want you to think about what are the physiological factors? What are those underlying factors that actually cause edema in a patient? So the first one, and we talked about this in our lectures already, is an increased hydrostatic pressure. So if the patient has an elevated blood pressure, that causes an increase in hydrostatic pressure, meaning that the patient's pushing pressure from the vasculature is higher and it exceeds that colloid osmotic pressure, and therefore fluid goes interstitial. The next one, if we're thinking about that same diagram, would be a decrease in colloid osmotic pressure. So if a patient has low albumin levels and their pulling pressure, that colloid osmotic pressure that causes the fluid to stay inside the vasculature is low, then the hydrostatic pressure overcomes it as well, even at a normal blood pressure. So more fluid ends up going interstitial. We also have one that I know that you know, and that's an increase in capillary permeability. And so we get edema from inflammation, but anything that causes increased capillary permeability. Also, the other one that you know is an increase in sodium. So if we have a hypernatremic state, that can lead to edema, as those of you know that have eaten entirely too much salt in a day, and then you wake up the next day and ankles are swollen or hands are swollen. Then the one that you know that you probably forgot about is a decrease in lymphatic drainage. So to remember way back to vital signs, when you weren't allowed to do blood pressures on a patient who had had a mastectomy, and that had to do with the likelihood that they had lymph nodes removed because there's a decrease in lymphatic drainage there. And if you were to compress or put a lot of pressure on that limb, that can cause fluid to get stuck in that limb because it can't leave through normal lymphatic drainage. So that fifth one was a decrease in lymphatic drainage. Now, our shortness of breath and dyspnea and cough may be due to pulmonary edema. So this is where there is then, the fluid inside the lungs. Two factors that help the nurse identify pulmonary edema is jugular vein engorgement, even when the patient is sitting up or in a semi-Fowler's position, and moist crackles in the lungs. The hemoglobin and hematocrit have been normal, but at present they are decreased, which may indicate hypervolemia. So remember, these are really, particularly the hematocrit is a concentration. And so we really need to think about how that concentration is going to change or decrease when there is an excess of fluid. So that's because, so why? There's a dilution of red blood cells and a decrease in red blood cells and an increase in water. So the nursing interventions that would help with this excess fluid volume. So definitely we need to monitor vital signs, report, keep track of elevated blood pressures, bounding pulses, monitor a daily weight, teach the patient to monitor intake, output, and daily weight. So when this person goes home, they need to make sure that they know how to do that. We are observing and tracking edema, making sure we're grading that to see if it gets better or worse. We do that especially in the morning. Monitor diet. We want to avoid excess sodium in the diet and any over-the-counter drugs without first checking with the physician. And we want the patient to have a diet higher in protein because remember, that's going to help increase the colloid osmotic pressure, which is that pulling pressure that will help the fluid stay in the vasculature instead of going interstitial. And we want to promote rest to promote diuresis. And then, of course, we will be giving any diuretics or anything that would be ordered. All right, we're going to move on to case study number 3. So case study number 3, we have a 19-year-old female who's had an appendectomy. So we want to assess the patient's fluid state. From the history and symptoms, this patient actually has what we call overhydration, or sometimes you'll see it even called water intoxication. So the early sign of intercellular fluid volume excess, which is really just another term for overhydration, was likely headache. Now, nausea could be one, but nausea is really not a good indicator after somebody has had anesthesia. So headache is a much better indicator that somebody is starting to have an overhydration state. So remember that in overhydration, we have a an electrolyte imbalance. And so that can mean that, or that does mean that fluid is starting to shift in and out of the cells. And so in this particular case, this means that the blood is basically hypotonic in nature. And so fluid is shifting into the cells and causing those to swell, which is what causes the headache. Now, if you're confused at all about why this patient who is getting a D5W, which is an isotonic fluid, is causing a hypotonic state, don't forget that D5W is the one that when the glucose is burned off, that it becomes a hypotonic fluid. So it's basically just giving a bunch of free water, which is also all the patient is taking in orally. The later signs would be the drowsiness, disorientation, confusion. And so those are important to understand that, again, that has to do with some swelling on the brain. The treatments and prevention. So a treatment in this particular case, it is getting bad enough that the patient is really having a lot of more severe symptoms. And they could actually do a hypertonic fluid. That isn't always what they do, but in this, it may be indicated in this case. Just remember the patient will be in an ICU setting for that. And the hypertonic IV solution would help to pull some of that fluid off the cells, particularly those in the brain, but elsewhere in the body too. The patient should be given fluids that do actually have solutes in them, that have electrolytes in them, such as broth or juices. And the patient should have been receiving saline solutions with some dextrose to prevent this in the first place. So there should have been other fluids that were given besides D5W. Way too much D5W was given in this case. All right, we're going to move on to number 4. Okay, number 4, we have a 68-year-old male with vomiting and diarrhea. So now we're wanting to know what is the electrolyte imbalance, and in this case, it is hypokalemia. Signs and symptoms of this imbalance: dizziness, muscle weakness, distended abdomen, diminished peristalsis. There are other ones as well. And the interventions that would help treat and prevent this in the future. So the patient is on hydrodural, which if you look that up, it's a hydrochlorothiazide. It's a thiazide diuretic. Thiazide diuretics are potassium wasting diuretics. Now, they're not as much of a potassium wasting diuretic as a furosemide or Lasix, but they still do waste potassium. And so if a patient is receiving a potassium wasting diuretic, then they need to ensure that they either have a lot of potassium in their diet or are taking a supplement. So in this case, it would have been indicated to take a supplement, because not only is the patient taking hydrochlorothiazide, but the patient is also taking digoxin. And so that, if you remember from the lecture, digoxin is a medication given to increase the contractility of the heart. So it is given to a lot of heart failure patients. The issue is that digoxin can become toxic when potassium levels are low, and the patient can start to see halos, which is an indicator of toxicity. So, sorry, that's my dog whining. So we do want to ensure that the patient is not going hypokalemic. So a supplement would be indicated in this particular case. When giving IV potassium, we have to make sure it's never given IV push, that will kill the patient, or not given as a bolus. It is given slowly through IV that is mixed in pharmacy. And so we do watch for irritation because potassium is very irritating. We monitor blood levels, we monitor any EKG type changes, and we want to make sure that we're encouraging those foods that are high in potassium, so make sure that you are reviewing those. Okay, we're going to move on to case study number 5. Case study number 5, we have a middle-aged female, diaphoresis, high temperature, nauseated, only intaking ginger ale, sodium is 129. So the electrolyte imbalance she has, along with other potential signs and symptoms. So she's definitely hyponatremic. She has a fever, diaphoresis, lack of food, so not intaking any food. And signs and symptoms could include abdominal cramping, muscular weakness, headache, nausea, and vomiting. When testing her urine, what would you expect the specific gravity level to be? So would you expect it to be high or low? Well, we would definitely expect this to be, the specific gravity to be low. So the body doesn't have enough sodium in the blood. It's definitely not going to have enough solutes in the urine. She was given a 3% sodium chloride solution. Her serum sodium level rose to 152. Now what should be checking for? Well, this is one of those cases where you treat one and cause the other. So we definitely need to be watching for hypernatremia signs and symptoms like flushed skin, elevated temperature, rough, dry tongue, tachycardia. And then the other thing we need to watch for, which we haven't really talked about, how these work together a lot, is hypokalemia. So if the patient suddenly is holding on to all that sodium, we have to think about how the body stays in homeostasis with those +1 charges. And so the body, if it's holding on to sodium, will get rid of potassium. So we need to monitor the patient for signs and symptoms of hypokalemia as well as blood levels with hypokalemia. Okay, we're going to move on to case study number 6. This is a 76-year-old female, was admitted to the intermediate care unit. So what is the physiologic reason for her edema in her lower extremities? So what we want to think about here is that she has extremity edema. She also has ascites, and her albumin level is decreased. So keep in mind that the albumin level has to do with the colloid osmotic pressure. It's our pulling force. So she has a decrease in pulling force in the vasculature, and so her hydrostatic pressure is able to overcome that. Her blood pressure overcomes that, and so more fluid spills out interstitially. She also has that third spacing, which is the ascites. Is it possible to have dehydration and edema at the same time? Well, absolutely it is. If the patient isn't taking in a lot of fluids, and the fluid that the patient is taking in is spilling interstitial and third space, then the patient's actual vasculature and cells can be dehydrated, where there's actually edema. So the patient can have a hypovolemic state or a dehydration state, and yet there's extra fluid interstitial and third space. She was given IV fluids for several days. If that fluid was administered too rapidly, what fluid imbalance would likely develop, and what signs and symptoms should the nurse monitor for. So again, always have to be aware of the opposite of what we're treating. So the patient could end up with hypervolemia or overhydration, either one depending on what the electrolytes and stuff did. So we'd be watching for that bounding pulse, elevated blood pressure, venous distension or neck vein distension, headache, shortness of breath, tachypnea, coughing, because we'd be watching for that pulmonary edema, so crackles in the lungs and chest pain. So I just want to make sure that we understand this, that in this particular patient, because of the third spacing, I mean, she had a 10-pound weight gain, and yet she's still showing signs that she is, dehydrated. So we have to understand that in this case, the weight is not the major sign that we are looking for. We want to look really at vital signs. So we want to be looking at that patient's, at their blood pressure, at their pulse, at their respirations. We need to know if this patient is still showing signs of dehydration, even though they're putting weight on. Okay, we're going to move on to the last case study. So take a moment or pause this and make sure that you have worked this out to the best of your ability. And so here we have a 68-year-old female who has a history of glomerulonephritis, which I'm just going to let you know, glomerulonephritis is, inflammation of the glomeruli and the nephrons. And so this does cause extensive tissue damage. And hopefully you remember what extensive tissue damage means for electrolytes. Okay. So if we look at question number 1, the low hemoglobin and hematocrit are often called the H and H, indicate what clinical condition and why. So here we really have the first time that we're really looking at a low or significantly low hemoglobin level. And this is a hard question. So we have to think about, if we have kidneys that are not functioning like they should, we need to think about all those things that the kidneys are responsible for. And so the kidneys are actually responsible for producing erythropoietin, and which stimulates bone marrow to produce red blood cells. So the low H&H here is actually indicative of anemia, and the reason for that is because of the kidney dysfunction. Her BUN and serum creatinine are elevated, which indicates that there's an increase in nitrogenous waste in the blood, okay? Or azotemia is the word for that. And though that information is found in your lab book. Serum potassium is 5.6. The normal range is 3.5 to 5. And why does this patient have hyperkalemia? Well, there's potassium retention because of the oliguria. So the patient's not having as much urine output as is normal. So potassium's not getting excreted. Now the other part here is what I alluded to previously, is that there was tissue destruction. And remember, when we have tissue destruction, that is where the potassium from inside the cells gets released into the blood. Her serum sodium is decreased, and a likely reason for that sodium level has to do with an excess in fluid intake. what symptoms does the patient have that indicate fluid overload? So here is a list of symptoms: weight gain, edema, increased blood pressure, bilateral crackles, jugular vein distension. The patient's going to have dialysis through a peritoneal cavity. So I know that we're not talking about this, but this is still just the principles of, hold on one second. Stop it, Cash. Go lay down. Go lay down. These are the principles that we are talking about. And so if the patient is getting a hyperosmolar solution, why do you think they chose this solution, particularly without potassium? Well, the hyperosmolar solution is to pull the excess fluid off the body, right? We want to pull all that fluid from the body as a way to excrete it. But we also want to make sure that we're pulling some of the potassium into the diacylate so that we can level those potassium levels out. If we gave too much hyperosmolar diacylate, then the patient can end up dehydrated because we'd be pulling too much fluid off of the cells. On the second day of peritoneal dialysis, her potassium is 2.8, which indicates hypokalemia, and we need to add potassium to that diacylate. Well, I hope that all of these make sense. I will be running well, we're going to have a video chat here in just a little bit, but I will also offer up some other ones during like office hours and things so that we can go through this if you have any additional questions. Thanks.